A very good evening, distinguished guests, seniors, colleagues and dear friends. On behalf of IMA Gorakhpur and as the Scientific Secretary of IMA, I extend a very hearty and warm welcome to all of you to this scientific meet on critical topics like anemia, ABG, cardiovascular disease, COVID and cancer. I am very hopeful that this meeting will be exciting, educational and full of learning for each of us. Next session is on breast cancer, role of screening and early diagnosis. And for this, I would like to invite Dr. Mahendra Harbola sir as a chairperson, who is MBBS from KGMC, 1979 batch, did his MS General Surgery in 1988. And post-MS, he worked as a chief resident surgeon in Gandhi Memorial and Associated Hospital. He is trained under the stalwarts like Dr. M.C. Mishra in oncology, Dr. A.K. Bhatt in pediatric surgery, Dr. Harish Chandra in urology, and he started his private practice in Gorakhpur in 1990. And he is doing all types of general surgery, pediatric surgery, oncosurgery, and gynec surgery. So over to Dr. Mahendra Harbola sir for introduction of our speaker, Dr. Navneet Kumar Tripathi.
So good evening everyone. So I'm the last man standing. I'll try to be quick. And my talk is on the role of screening and diagnosis in early breast cancers. So as we know that breast cancer has now become the most common overall cancer in both men and women. In fact, in India, it accounts for about 25% of all the patients who have cancer, followed by cervical cancer, ovarian and even oral cancers. As we know that the burden in our country, the burden is quite high and our patients have a poorer outcome as compared to the West. And the reasons can be that we have advanced stage presentation patients. Patients come mostly in stage 3 and 4. We have no organized mammographic screening program. There is a lack of general awareness among women regarding their breast health. And the social issues like the concerns of women are not properly addressed in a family. And lastly, that we have not very robust medical infrastructure. Also, the biology of our patients is different from the Western patients, as many studies have now shown. And our patients are more difficult to treat as we get patients in slightly younger age. They have more triple negative breast cancer patients. They are more high-grade tumors, and again, they present in high stages. So overall, the picture in our country is we get more advanced and more aggressive tumors. Coming on the risk factors, we can broadly categorize the risk factors into two groups. The first is the fixed factors which we can't change. So the first is the age factor. So as the age will increase, the risk of a woman developing breast cancer will increase. Followed by the race, personal history of breast cancer, prior history of radiation to the chest wall, and other factors like early onset of menarche occurring less than 12 years of age, late menopause after 55 years, and the first childbirth happening after 35 years, which is very common these days, especially in metros. Again, family history is very important. A lot of patients have strong family history of breast and ovarian cancers, especially the two mutations which we talk of these days is BRCA1 mutation, which has got a 70% lifetime risk of development of breast cancer, and the other is the BRCA2, which has got about 50% chance of subsequent development of breast cancer in a woman's life. The second group is the lifestyle factors, which is again epidemic these days. Of these, the most common is the obesity. Women are more obese these days. Fatty diet, lack of physical activity. Again, there is a fad of avoiding breastfeeding in some population. Again, smoking and alcohol intake is again important. And lastly, hormone replacement therapy, especially in the postmenopausal age group. However, the absence of these risk factors doesn't guarantee that a woman will not develop breast cancer. In fact, about 80% women who have cancer doesn't seem to have any risk factor. At the same time, women with risk factors may not develop breast cancer in their lifetime. So the crux is that breast cancer cannot be prevented at this time. Our aim should be to detect breast cancer at its earliest possible stage for best clinical long-term outcomes. Now the question comes, how to detect breast cancer early? For this, we have two two things can be done. The first is to raise awareness among women regarding their breast health. Women should again consult a nearest physician or a gynecologist if they develop any symptom in their breasts. Second is a breast cancer screening programs. Now for screening, screening has shown to reduce breast cancer mortality as is shown in various studies, and where there are various options. The most common is our yearly digital mammography, which should be done after 40 years of age. Other options being a clinical breast examination by a physician once a year. MRI can be used in only some specific populations where the risk of breast cancer is more than 20% or the patient or the woman is a BRCA mutation carrier. Ultrasound as a screening modality is not recommended. However, in places where mammography is not available, it can be used due to some logistical reasons. Coming on to digital mammography, again, this is the only screening modality which has shown to reduce breast cancer mortality. It is the only modality which has been recommended to be used as a routine screening program. Again, the important thing is to consider the age when to start screening. Again, this is a very controversial topic, but in India what we are following is that after 40 years of age, every woman should have a yearly mammogram and a clinical breast examination, and that's what we are following. Now again, there is one advancement of the mammography which is the DBT or a digital breast tomosynthesis, which is now available in Lucknow, and this is a 3D mammography, and various images are taken in various planes, and the advantage is that very small lesions which are present in dense breast can be picked up by this DBT, and also we can take biopsies from lesions which are not palpable. This is done in a mammographic suit, and we can guide the needle to the exact location where the tumor is. Coming on MR mammography or breast MRI, again it is a very useful investigation in a small subset of patients. It is useful in women who are young, who have dense breasts, as mammography or ultrasound may skip lesions in women who have dense breasts. It is done with a dedicated coil and with the IV contrast. Indications of a breast MRI are in young women having dense breast with some suspicious lesion on ultrasound, screening for high risk cases in pregnancy, and it can be used as an adjunct to a mammography when the findings are not very clear. Lastly, I like to touch some points which are of clinical significance. That currently age is not a very good criteria to judge regarding the malignancy, as the breast cancer age has come from 50 to 70 years of age to now currently it is now peak is in between 30 to 50 years of age. So younger women doesn't mean, if the patient is young, that doesn't mean that she may not have a malignancy. She can have malignancy, and you have to rule that out. Irrespective of age, if you get the patient of breast lump, always try to rule out malignancy. Also, we should never operate without getting a tissue diagnosis. At times we are tempted to perform excision biopsy, but always get a cytology or a biopsy done before operating on a breast lump patient. Again, family history. Any patient with a breast cancer history, always try to ask for history of ovarian, prostatic, pancreatic, or history of melanoma in the family history, as now currently we have the gene testing which is available, and we can offer the gene testing to the patients for further management. Now for FNAC, at times we get very unusual reports like atypical ductal hyperplasia, ADH. We get reports like neoplastic lesion or suspicious for malignancy. So after we get a report like this, we should not straight away go for surgery. We have to go for a core biopsy, and core biopsy is very easily performed these days. It is performed by a needle biopsy. It is done in a OPD setup, and it is done under local anesthesia. So the advantages are that we can get a clear-cut diagnosis, we have a faster decision making, and also we get some additional information like regarding the grade of tumor and the ISU markers. So always perform a core biopsy when the results of FNAC are not very clear-cut. Again, a new modality has come, which is a PET scan. PET scan is not done for a diagnostic test. It is done to stage the patients when the breast cancer patient has been diagnosed. It is required for patients who are locally advanced, like stage 3 or stage 4. For early stage breast cancer patients, we can skip PET scan as it is a costly investigation. The problems being, as I told, it is costly, it is not available everywhere. I think it is now available in Gorakhpur. And the CT images of PET scan are not very high resolution. So this can be avoided in early stage breast cancer. PET MRI has recently come, and it can be of use in the future. As I told, the gene testing is available these days. So it is the two most common genes are BRCA1 and 2, which is the most common genes. And we have two options currently for these gene testing. Either we can go for a BRCA1 and 2 gene test, or there are some panels, which are the multi-gene panels or the panel testing, where apart from the BRCA1 and 2, other genes like ATM, PTEN, CHEK2 mutations are also can be tested. The indications of gene testing is a young patient less than 45 years, triple negative variant less than 60 years of age, bilateral CA breast patient, male breast cancer patient, and patients having very strong history of breast cancer, including both breast or ovarian cancers. So the take-home message is that breast cancer is the most common cancer in women, and screening mammography should be performed in all the women starting from 40 years of age. Breast cancer surgery should not be performed in women without getting a tissue diagnosis. Either a FNAC or a core biopsy should be available. And breast cancer can be cured if the patient is detected early and it is treated adequately. Thank you.
So there are mammography, there are people doing ultrasonographic mammography. Is this?
So yeah. So what they call it as a sonomammography.
Yes, sonomammography.
So sonomammography is not mammography per se. It is ultrasound of breast. So the ideal thing is we should have a digital mammography after 40 years of age. Ultrasound can be performed in young women less than 40 years of age. For screening purposes, only X-ray mammography has been shown to be useful, not ultrasound or a sonomammography. A lot of times I advise the patients and they come with a report of the ultrasound. So that is not the correct approach. Yes. After 40 years, once a year, and a clinical breast examination by a physician.
40 years till when?
Till lifelong. Ma'am, this is what we are following in India. There is a lot of controversial, like some in America, it is from 50 year onwards. So after between 50 to 40 to 50, there are some specific groups. But here in India, we have now guidelines. We are following from 40 years of age.
So what we have read, I think young patients where we have this monoglandular tissues, their mammography is of
less use, yes.
Ultrasound is more important.
Yes.
Then you are saying sonomammography.
I am saying less than in young women, ultrasound should be done. So for screening.
You are not accepting it as a screening method.
No, ma'am. It is not useful for breast cancer. It can be good for benign breast lumps. Yeah, for fibrocystic breast disease, but not for malignancy. For that case, breast MRI is the better investigation for young women.
Dr. Navneet Tripathi, what is the current status of the blood test for early detection of breast cancer?
So that is like still in the, there are a lot of studies which are being done for liquid biopsy. But then currently we are not using it routinely for detection or recurrence of breast cancer.
Thank you for the wonderful talk.
Thank you.
Mother has breast cancer, and then we do BRCA genes. So she comes out to be positive.
Yes.
So what should the sibling do? I mean, her daughter.
Yeah. If the index patient is positive, if the index patient is negative, the story ends. Nothing needs to be done. If the index patient is positive for any mutation, then the siblings, the sisters first, and then the daughters, they need to be screened for the testing.
So suppose they come out to be positive.
Yes.
Then what do you do?
Again, ma'am, that is a different, discussion altogether, because then you have to go for a preventive surgery and all. Chemo prevention comes, the role of tamoxifen, and like what Angelina Jolie did in the US, she had a prophylactic bilateral surgeries. So that is again a very, that has to be discussed with the patient. What options, all the options need to be given to the carrier.